What is up, guys? We are back again with another episode. And in today's episode, we are joined by the lovely Nicola, as per usual, because we are continuing on this female-related health series. And in today's episode, we're going to be talking about endometriosis, right? Now, from the offset, as I was just saying to Nicola before this call, like I don't have a huge amount of experience coaching people with endometriosis. Like, yeah, I've read about it, but that's one thing. You kind of want to have, especially if we're going to be giving you practical information, you kind of want to have that theoretical knowledge and then also that like in-person actual experience, right? And as I'm not a woman, I've obviously not experienced this endometriosis myself. And because I've not coached women with endometriosis, I'm basically going to sit back and let Nicola give us a masterclass here today, right? So with that out of the way, Nicola, what's the story with endometriosis? Like what even is it?
Yeah, so your endometrium basically is the lining of your uterus or your womb. And endometriosis then is a condition where patches of endometrial-like tissue, they grow in other parts of the body, so including your pelvic cavity, your ovaries, your fallopian tubes, and they can even pop up on the bowel, bladder, and then like very rarely the lung. So the tissue, while it's not the same as the lining of the uterus, it responds to hormonal fluctuations, just like in your menstrual cycle. And so each month that tissue can, build up, kind of break down and even cause bleeding, which then that all has the knock-on effect of, causing inflammation, irritation to that surrounding tissue, which can lead to a lot of pain, which is really characteristic of endometriosis. So unfortunately, it's a diagnosis that, can take up to 8 years to diagnose. It has complicated kind of symptomology, like you're saying. Those kind of patches of tissue can pop up in numerous different places. But the main kind of symptoms would be kind of women complaining of painful, heavy periods, a lot of pelvic pain, abdominal pain, fatigue, diarrhea, a lot of kind of GI issues, low back pain, and really intense cramping. Some women might not have any symptoms at all. And even the severity of the disease isn't exactly, but the severity of the symptoms doesn't necessarily correlate with the extensiveness of the disease as well. And like I was saying, a lot of those symptoms there, they can overlap with a lot of things like IBS, IBD. So even a woman who has kind of mild endometriosis, they might kind of go kind of seeking for help, and it might kind of be wrote off as IBS or something similar. So that's why it can take a long time to diagnosis. And as well, it's a difficult one to diagnose because ultrasounds, pelvic exams, they might not exactly pick it up despite someone having all that pain. So the gold standard for diagnosis is a tissue sample, which obviously would involve kind of surgical exploration, which a lot of people don't want to do, which is understandable.
Yeah, like it sounds kind of shit, to be honest. But it sounds like there's a lot going on, right? There's a lot of, it almost sounds like, with cancer, like you have cancer in one side of the body, and then, if it progresses enough, it can go to other sites of the body, right? So it sounds kind of similar to that, which, that's scary enough in and of itself. But you've basically got this tissue, this endometrial lining, this type of cell, whatever, and then it finds itself through whatever mechanism in another part of the body, right? And I don't know if it was you or Gary that wrote this down in the notes that we have, but I'll just go through the like common sites because you kind of touched on them there. But the reason I want to bring them all up is because you can see that if this is causing pain and whatever else in these different areas, like if it can get to a variety of different areas, you're going to have a variety of different like presenting symptoms. Like if you go, oh, I've got pain over here, or I've got pain over here, I've got pain over here, like as a doctor, even, how are you going to go, oh, that's endometriosis? That's exactly what that is, because it's so disparate, right? But anyway, I'll just go through them. So ovary and ovarian fossa, 57 and 32%, anterior and posterior cul-de-sac, posterior broad ligaments, uterosacral ligaments, it's 46%, pouch of Douglas, 30%, bladder, uterus, fallopian tubes, sigmoid colon, appendix, round ligaments, and then other, vagina, cervix, recto-vaginal septum, cecum, ileum, inguinal, I hate that word, I can never say it, canals, perennial scars, ureters, umbilicus, and then extra pelvic sites, you know, and like you said, that could even be the lungs and stuff, you know.
Exactly.
So that's a lot of different areas. And yeah, okay, it might all be like, you know, in and around your abdomen, right? You're like, oh, there's some abdominal pain. But like anyone who's had pain in their abdomen, right, even from like food or whatever, it's kind of hard to pinpoint exactly where you're feeling it. You're kind of like, yeah, maybe it's the lower left, no, maybe it's a little bit higher. Like it's very hard to pinpoint exactly what's going on. So if we've got an issue or a problem here where the individual that's feeling this stuff, they feel the pain, like the pain is there, like regardless of what causes it or whatever, the pain is there. It can be very hard to pinpoint exactly, oh, this is where the pain is. But then also they go to present to a doctor or whatever, and first of all, second of all, it's very hard to describe what pain is. You know, you're kind of like, oh, it feels very sharp, it kind of feels like electricity, or it kind of feels like this throbbing. Like there's so many different varieties of that painful sensation. And then if you're kind of going, I can't really pinpoint exactly where it is, it kind of feels somewhere in my abdomen, and then the doctor is going like, this could be anything. Like this could literally be like so many different things. It leads to a situation where, like you said, like the average diagnosis time is like 8 years or whatever, which is, you know, that's kind of again, another shit fucking run with this stuff where you're kind of going, right, I have this problem every single month because there's a hormonal aspect to this, which I'm sure we'll talk about in a second. Every single month I'm getting like extreme pain, for example, and I go to the doctor and they're not able to tell me what's going on. You know, they're not able to go, oh, this is exactly what the problem is. And you're doing that for the guts of 10 years trying to figure this stuff out. Like you're in pain, you're not getting help because you're not getting like an accurate diagnosis. It can be very frustrating, I presume, you know?
Yeah, absolutely. And that's the biggest thing, is that the time to diagnosis, then that could mean, you know, a woman's in pain for 8 years, and it's kind of a chronic pain syndrome. And even the knock-on effects of that is things like a lot of kind of sick days in work, again, just kind of fatigue, disrupted sleep. So there's more, I suppose, like mental disturbances as well associated with endometriosis.
Yeah. And on this, is it just like this is, I do know the answer, but is it just a pain thing that we're looking at here? Is it just oh, this is just something that causes pain, no big deal, like, you know, other people are in pain, who cares, you know? Is it just a pain thing, or is there something more going on here that we're kind of like, right, actually an earlier diagnosis would not just help with the pain, but an earlier diagnosis would also help with other things going on?
Yeah, so the other kind of main one that we're looking at is fertility. And with someone getting a diagnosis of endometriosis, it can be, you know, pretty harrowing, because it's a huge cause of infertility in women, and particularly with the formation of endometriomas, which are cysts within the ovaries that are associated with endometriosis. And again, if they are left untreated for a prolonged period of time, they can essentially almost like erode away at the ovary and then cause infertility as well. So it's a huge cause of concern for a lot of women. And then particularly, I know from one of my own clients, again, who was looking to get pregnant, who was on the pill, again, to regulate some of the symptoms, but then coming off the pill just, you know, led to this huge cascade of pain. So, you know, a lot of women, you know, need one, you know, to come off the pill to get pregnant, obviously, but we'll need kind of hormonal treatments, like, you know, say like IVF as well to get pregnant. Not all the time, but sometimes.
And again, like that is one of the things that as I said, I was telling you before this, like I often, when I'm researching these things, I'll try to see what like the real world experience is in terms of like what people are experiencing, what they're talking about. And that seems to be a very common issue for people with endometriosis. They're kind of like, right, I've got to a situation where my symptoms are somewhat managed. Like there's still pain present, there's still whatever, but I have a combination of, you know, painkillers, the pill, or whatever it is. And they're like, I have things managed. But then they want to get pregnant, you know, they're basically, their situation changes and they're like, yeah, actually, I wouldn't mind getting pregnant now. That's kind of on the cards. And now they have to mess with this, you know, carefully balanced, you know, treatment regimen that they have. And they're going, okay, now everything, all the wheels fall off the wagon. What do I do here? The things that I used to do that used to be able to help me, I can't really do them now because they're antagonistic to getting pregnant, etc. And so that's kind of a hard place to be in. Now, obviously, look, we can't, on this podcast, we can't help with that. That's not the purpose of this podcast, at least. But it is something that people commonly say. So if you're just coming to this and you're going, oh, I just got a diagnosis of endometriosis, I don't know what the story is, like, this is something that potentially you have to think about ahead of time, ideally, because you can better prepare yourself. But also, if you're someone that has been dealing with endometriosis, either known endometriosis or unknown, like, this is something that potentially in the future you're going to have to deal with. So I suppose it makes sense right now to kind of go through the symptoms of endometriosis. I know we touched on them a second ago, but we're talking about this thing that has a very, I don't know, disparate effect. You're kind of like, oh, abdominal pain. Is that all that you have to go on? Is that all that you're kind of like, oh, someone comes to you, random abdominal pain, it's going to take you 8 years to diagnose this as endometriosis. But are there any other symptoms that we could potentially look at and go, oh, these also help us diagnose what's going on? Especially, like, say, for example, like I mentioned earlier on, that there seems to be some sort of hormonal contribution to this. Is that something that we can use? And the reason I want to ask this is because, like, I know it's very hard to diagnose yourself, right? And I'm putting that in inverted commas or air quotes or whatever, because, like, obviously you don't diagnose yourself, right? But if you can go to a doctor with an idea, like, you've better, like, oh, I've got these symptoms. You might not have thought that they were related, but you're like, I actually do have these symptoms. It can be very easy, or easier, for a doctor to kind of go, okay, so you actually have a variety of symptoms here. I'm going to be able to make a diagnosis as a result of that, rather than coming with just one symptom, But anyway, so what are kind of the symptoms of endometriosis? Like, what are people actually like experiencing?
Yeah, so I suppose in a woman presenting with pelvic pain or heavy painful periods, endometriosis is something that should always be considered or ruled in. So yeah, painful heavy periods, prolonged periods, bleeding in between periods as well, mid-cycle pain, kind of diarrhea, bloating, kind of painful sex. Even pain on movements sometimes, so even in the lower back, kind of progressive pain. And that can be down to a number of things. It's a kind of an estrogen driven state, but also an inflammatory state. And it can cause chronic changes to the nervous system, and I suppose a sensitization to, particularly to our sympathetic nervous system, which is driving on that pain.
And again, like, as you said, there's a variety of symptoms there, and some of them are very everyday, or whatever you want to call it. Like, this is just normal for a woman. You're going to be like, oh yeah, like, sometimes I have diarrhea, sometimes I have constipation, it's related to my cycle, no big deal. Like, you're just going to kind of write that off and go like, oh yeah, like, loads of women experience that, no big deal. You might be like, oh, around, say, I don't know, ovulation, for example, you might be like, oh, like, I feel a bit more pain there, and then during, like, in the lead up to or during my period, I feel more pain there. But you're like, oh, that's just me. That's just normal for me. I've always felt like that, whatever, It's very easy to write off a lot of these symptoms as just being normal, because a lot of women will have similar symptoms. They will have similar experience, like, throughout the month. So again, very easy to just go, no big deal. Like, I have these really intense periods of pain, but it's not related to these other symptoms that I have, But again, it potentially is.
Yeah, definitely. It's always something that needs to be ruled out, but again, the diagnosis is tricky. So you might just be going off clinical suspicion symptoms to kind of, diagnose it without kind of surgical exploration.
I don't know if you want to talk now a little bit about, like, what's kind of causing this pain. I know we did say it a little bit in a second ago, in terms of there is a few things going on that cause this pain. But the reason I want to go through this is because, like, I always find, at least for me, when I know what's going on, I'm like, okay, so that's actually explaining the pain. So, like, what's actually happening here to cause this pain?
Yeah, so it seems to be mostly through inflammatory changes, and endometriosis related pain is kind of associated with an increased production of, inflammatory and kind of pain mediators in the body. So you'll see an increase in, like, cytokines, etc. There also seems to be an imbalance of kind of our nerve fibers. So, like I was saying, the sympathetic and kind of sensory nerve fibers, they seem to be kind of off balance and have more of an endometriosis related pain as well.
Yeah, because again, it is, again, at least for me, I'm kind of going like, okay, we've got this little bit of tissue, this little bit of cell that has gone somewhere else in the body that it shouldn't be. Why would that cause pain? You know, it's like, okay, yeah, it shouldn't be there. Maybe, yeah, that's it. It's an irritant, if you will. Again, I'll just put that in air quotes. But it's a lot more than that, right? That cell is like, you know, or those cells, that tissue is like attaching, again, I'm putting that in air quotes, to these other tissues that it shouldn't be in. And then as a result of that, it's still acting somewhat like the tissue that it was beforehand. So the signals that, you know, your endometriosis, it sheds monthly, whatever. So it's still reacting to those same signals. So it's still doing some of the similar things that it would do if it was in the right place. So if say it's, again, let's say it's gone to your ovaries or something, you know, if it's attached onto your ovaries, it's still responding to those same signals, right?
Exactly,
So,
yeah.
you know, it's basically having this, like, you know, shedding, if you will, like it has a bit of that localized bleeding, inflammation, etc. Then also it seems to, like you were saying with the nervous system, it seems to be pushing changes, we'll just say like that, you know, it seems to be changing the nervous system in a way that makes you somewhat more sympathetic dominant, not overall, but just in around there. And as a result of that, you have this increased sensitivity to that pain and increased pain in general, you know. So it doesn't sound like a very, you know, fun time, you know.
No, not ideal, not ideal.
I think it was Gary to put in some symptoms here of endometrius related pain. There's other ones which we've talked about some of these on the podcast before, and also we will talk about some of them in future. We've got this like dysmenorrhea. So again, we've mentioned this, painful, sometimes disabling, if I can't even speak here, disabling cramps during the menstrual period. But again, a lot of people write that off. They go, yeah, look, I always have pain in my period. I just take a week off work and I just, you know, sit on the sofa with a hot water bottle or whatever it is. You're just like, that's just me, right? You know, pain may get worse over time. It's progressive pain. You know, there's a low back pain linked, you know, to the pelvis again here. So again, a lot of women will find they have low back pain during their period. So you kind of write that off and go, look, that again, that's just the way I present. That's just, you know, the way things are. But then you can also have this kind of chronic pelvic pain, right? And I think that once there's this kind of chronic pain, I think people are a little bit more like, they pay a little bit more attention to it. They're kind of going like, oh, this is something that's always either it's a low grade pain or a high grade pain. It's always in the background. So for them, they're kind of going, okay, I need to get this sorted, you know? Whereas I feel like with cyclical pain, like people are kind of like, oh, okay, this is fucking terrible at the time, but at least I have whatever 3 weeks off from this, you know? So the chronic pain, I feel like people kind of really do pay a lot more attention to, but there's more to it then as well. Like you mentioned, I can't even say this word just in case anyone's wondering, dyspareunia, whatever. But anyway, it's basically painful sexual intercourse, right? And again, as I said, like I often go through like forums and stuff when I'm researching a topic, I'm like, what's people's experience? And this is something that a lot of people seem to be saying, where they're like, look, they used to have an intimate relationship, they used to have whatever intimacy, and now they've got progressive endometriosis, and all of a sudden they're kind of going like sex is just not enjoyable anymore. It's not, like, first of all, they're in pain a lot of the time, so they're not in the mood for it, right? But then also when they do it, they're like, this is just painful. It's not enjoyable. It's not an enjoyable experience overall. So again, that sounds pretty fucking shit. And then we also have this dysuria, which is urinary urgency, frequency, and sometimes painful voiding, you know, like basically pushing things out. Why are all these words always in fucking German? Schmerz, which is pain associated with ovulation, which again, if we're saying, okay, this is somewhat, you know, hormonally related, well, it's not somewhat, it is hormonally related. You can imagine that during ovulation, as we talked about in a previous podcast, like the hormones change throughout the cycle, right? So during ovulation, you might be like, all right, that's actually quite painful. I feel that, right? And I know a number of women say that they can feel ovulation, right? They're like, oh, I can feel ovulation occur. And that oftentimes when I hear that, I'm like, that, first of all, that sounds pretty cool. Like, it's like, you know exactly where you are in your cycle. But other than that, I'm like, maybe there is some sort of, you know, endometriosis connection here where you're actually feeling that little bit of pain because, you know, the whatever endometrial lining or whatever has gone to this other area, and you're able to feel that ovulation, and you're feeling it as like, oh yeah, I'm feeling like a release of an egg or whatever, but really you're just actually feeling that kind of estrogen mediated pain
Exactly.
So it's a weird one with that, at least to me, you know. And then the final one there is just bodily movement pain. So, you know, if you try exercising, standing or walking, you're just in pain, you know. Again,
Exactly. Yeah.
sounds like a fairly fucking shit time. But do you have anything to say on any of those kind of pain related issues?
No, not really. I suppose with any of them, it just should, raise your suspicion for endometriosis. Like I said, it's mostly underdiagnosed. So having any of them, it should be something that you talk to your GP about.
Hmm. And I think it was Gary that put in these in the notes, but the risk factors. Do you want to talk about the risk factors or any of the kind of like reduced risk? Because again, this is one of those ones. I did biochemistry for my degree. I really like biochemistry. That's my jam, right? And most diseases or whatever, I'm like, yeah, it's cool. Like at least we can see the etiology or etymology. I can never remember which one of those words is right, but we can see what's going on here. And I'm like, it's cool. It's cool science, right? But the one disease that always freaks me out is just prions diseases, right? Which is basically misfolded proteins. I'm like, there's nothing you can do about this, right? It's like, this is just random, right? Like I would never, like I literally will go to a country and I will eat whatever the local cuisine is. If they're like, yeah, look, it's fish eyeballs and goat's fucking toenails, I don't know, I don't care, right? I'll be like, yeah, let's try this, right? But when someone goes, oh yeah, we're eating brain, for me, I'm like, oh, like the risk of prions diseases here, even if it's so low, it just freaks me out so much, right? And that's the way a lot of people feel with just diseases in general, right? They're kind of like, how did this happen? Why did this happen to me? You know, like people back in the day were like, oh, like I'm a good person. Why has God done this to me? Like, why has God like forsaken me and given me this disease or whatever? People still feel that in this day and age. They might not blame God, but they're like, I'm a good person. Why the fuck did I get endometriosis? Like, what did I do something wrong here? Did what happened, right? And we don't have like a perfect, like, this is exactly what happened. Like, this is the day one. This is exactly, you did this trigger hit here, whatever. We don't have that, And one of the things that I always find very hard, or at least emotionally, I always find very hard when people deal with like any kind of disease or illness or whatever. Like everyone always wants to blame themselves. They're like, did I do something wrong? Is it me? Did I don't know, I smoked one weed or whatever, back in the day, and it was that, like that kind of thought process like does go through everyone's mind when they get some sort of diagnosis. Is like, what did I do wrong? And I don't think that's very helpful emotionally or scientifically, medically. But having said that, there are still some risk factors and factors that reduce your risk of endometriosis, because this is something that like you develop later in life as well, and that's tough. But anyway, so risk factors here. What's the story?
Yeah, that's the thing. We can't exactly like nail down why exactly women get endometriosis, but we do know that there are some increased risks. So it would be like your prolonged estrogen exposure. So that would be like having, your period early to having kind of a late menopause, not having any children. That's another one. Shorter cycles, heavy periods then. And it's also linked with some women that are kind of tall and have a low BMI, kind of weirdly. And then reduced risk would be, having babies, and then breastfeeding as well, or having a late period.
Yeah, like some of the ones, again,
late first period, I should say.
Yeah. Some of those ones are a bit weird, because like someone who's like, say for example, the tall, right? That's, again, height is estrogen dependent. Well, somewhat estrogen dependent in terms of like your growth plates fuse because of estrogen, right? Like that's what's fusing your growth plates. Like if you're a guy, the reason most guys are taller than most women is because they have less estrogen, right? Like if you genuinely wanted to make your male child as tall as possible, like you could give them some sort of like suicidal estrogen receptor inhibitor, right? Like you could literally just be like, right, I'm going to give you, I don't know, even like a selective estrogen receptor modulator. Like you could do that. You could be like, right, we're going to completely shut down aromatase, for example, and they have no estrogen. Now it would probably fuck up their brain in multiple ways, right? But they would be really tall. So you can imagine here in a situation, this is hormonally related. Endometriosis is hormonally related. So if you're taller than the average, something has happened here in regards to estrogen. Now, it's in being taller is generally associated with lower estrogen levels, which is kind of a weird one, because then you're kind of going, well, if I have lower estrogen levels and this is estrogen dependent, surely that would be protective, So it is a weird one. But having said that, again, the body is fucking weird. We don't like some of these things were like in normal times, this is what happens. But then in this weird situation over here, this happens. But either way, it does seem to be a lot of these things are, again, hormonally related, and it's not like we control our hormones. It's not like we're like, well, to an extent we do, like obviously, like we talk about all the time, good sleeping patterns, good health patterns in general, like they generally lead to a better hormonal profile. But it's not like you are going in and going, oh, I do these different things and my testosterone goes up like this, or I do these different things and my estrogen goes down, or what. Like it's not that simple, like you can be doing everything right and still have things, out of whack, if you will, right? So I don't think it's very helpful. I think it's important to know, but I don't think it's very helpful to really go like, oh, these are the risk factors and these are the reduced risk factors, like one of them is like basically pregnancy, like if you are whatever, let's say a lot of women these days have children in their 30s, right? Like they're not going to have them in their teens and their 20s. It's not really helpful to be like, oh yeah, like you're 32 now and you've got endometriosis. Like if you actually wanted to reduce your risk, you should have had 2 children by now.
Yeah.
It's not really helpful, right? It's like, yeah, okay.
No, definitely not. The one thing I suppose it would raise your clinical suspicion, so it might lead to a little bit earlier treatment, but then again, still the treatments aren't fantastic for endometriosis anyway.
Yeah,
which will
as well. Like, and this is also another one where you're like if you've got a like earlier menarche, so you had your period earlier, it's like you didn't control that. you didn't decide like, oh yeah,
control, exactly.
I wanted to be 9 years old having a period, because that 8-year-olds and stuff, like it's not like you made that decision, Now a lot of that is related, especially because I know people always ask this in the modern day, like women seem to be having periods earlier in time, and that seems to be associated with just the abundance of food. You're able to put yourself in a better, I'm gonna say hormonal situation, but it's more of like that abundant situation. You've got higher levels of growth hormone, higher levels of insulin, etc., because of the abundance of food. But that's just one thing. But again, that doesn't, like, it's not something that you chose, even as a child. Yeah, okay, like you quote unquote choose to eat, but you're just eating the food that your parents gave you, or like the people around you gave you, so it's not like you chose, oh, I'm going to do this thing. Like there's no way a child is thinking like, this is going to make my period come early.
Exactly. You've little control over it at the end of the day.
Yeah, and that's important to understand. It's like, look, all of this stuff, all the risk factors and stuff, you don't really have a huge amount of control over them. But if you do notice, you're like, okay, I've been having these symptoms, I've been having like this, undiagnosed pain, and then you look through this kind of like risk factor list, and you're going, okay, Jesus, actually, these are all me. Like I'm ticking all the boxes here, or a few of the boxes. It can help you kind of go, okay, I think I should go to the doctor about this, because this is one of those things. Like guys always get the blame here, where they're kind of going, oh, like guys don't go to the doctor. Like they literally have like a cancerous mole on their face, and it's so obvious, and they're like, it's grand, like it's fine, it'll be grand, whereas like women tend to go to the doctor more. They'll go, well, maybe not more, but they tend to go about the issues that they have. They're like, I have this issue, what's going on? But stuff around, first of all, like menstrual related stuff, you can be kind of hesitant to go to your doctor. But also, if you're kind of going in, you're going, I have this undiagnosed pain, and especially if maybe you're a little bit overweight, right, and you're a bit conscious about your weight, you can go in and go like, I don't want to go to the doctor, tell them this kind of stuff, because I know they're just going to tell me that, oh, you need to lose some weight, or oh, it's just it's just normal, or whatever. Like it can be very hard to go into your doctor and first of all get a diagnosis with this stuff, but to go in, even just to go in, like to actually talk about this stuff, and it can be very hard to do. And unfortunately, again, this is somewhat time dependent, because again, if we're talking about fertility, like you don't want to reach that kind of in your 30s age, because that's the general age people are having children these days. You don't want to reach that in your 30s age and realize that undiagnosed pain that you've been having for the last 5 years, it's actually leading to reduced fertility now when you actually want to have children, and this is especially true as well if you have been on the pill or whatever, and you were just on the pill because maybe whatever, you were a 14-year-old or something, and you're kind of like, yeah, I'm having these like painful like periods, and the doctor just goes, yeah, okay, well, we're going to put you on the pill, and you've basically been on the pill for whatever the last 15 years or something. You might not even know. You might be just like, oh yeah, like I still get these like painful issues or whatever, but you might not know, and then you come off and all of a sudden you're dealing with endometriosis, you know? So it is important to know the different risk factors. Like they're not very helpful in terms of what to do, but they're helpful to know what's going on.
Exactly. And it's important to know, I suppose, what's a normal period and what's a normal level of pain to have around menstruation as well. And that's something that we don't really learn in school. And that's why a lot of women put up with it. And that's another reason why the diagnosis is so delayed, because they just expect it and accept the pain.
Yeah. And also in the workplace as well, like it's one of those things where, you know, if you've got pain, you're kind of like, oh, I can't take a week off work here. I can't, like, you know, I just have to, you know, grin and bear it, go in. Like there's no support there. And that's not to say like, you know, we just give women archetypically just like, oh yeah, every 4 weeks you just take the week off or whatever. Like obviously lots of people don't want that and they don't need that. But it is one of those hard situations in society where we've basically created society that you should just be working that whatever 50 weeks of the year, you get your 2 weeks off or whatever. And yeah, okay, you get some sick days, but if you've got this chronic condition that makes you in pain, there's no real support for that, which leads to a lot of situations or a lot of downstream situations where, you know, maybe you choose an easier job. It's not the job that you wanted, but you know they give better support, or that they potentially have like maybe, I don't know, it's easier for you to just, I don't know, sit at a desk or something from home. You're kind of like, oh, okay, I can do my work from home and, you know, I don't lie in my bed and type on my laptop or whatever. Like you're choosing jobs because of your chronic condition here. And that's not right in my mind. I'm like, you know, ideally we have a society that, you know, we help everyone. Now, again, it's one of those hard ones. I don't have the answer here. Do we go, oh yeah, like if you have endometriosis, you just get every whatever 4 weeks off or whatever? I don't know if that's the best answer there, but this stuff can be hard to deal with beyond just the bodily pain, like the actual, I don't know what you want to call them, like societal implications for this. They're hard as well.
Yeah, exactly. So a lot of more sick days from work, and as well avoiding social situations as well. And like I was saying, you know, increased likelihood of mood disturbances through lack of sleep, stress, pain. So there's huge more knock-on effects of that.
Yeah, and again, there's no like, oh, here's the protocol that we deal with this stuff with, you know. And again, it's one of those hard ones because I think it was Spain recently. They gave more like days off for menstrual issues.
Yeah, it's brilliant.
So like stuff like that, obviously helpful, especially in cases like this. Now, I'm never a fan of those ones where it's like, oh, you must take these days off, because like you basically, if you were forced to take every 4th week off or so, you'd be like,
yeah,
I don't need to do that, you know. I can keep working, you know. But when they give you the option, it's like, okay, cool, like this is helpful here, you know. But anyway, look, we are not we're a quasi-medical podcast, I suppose you would say, but we are not predominantly a medical podcast. And what we really care about is what can we actually do about this stuff? What can we actually do to help with endometriosis? And unfortunately, there's not a lot, right? There's not exactly like, oh, do this, you know, exercise plan, do this nutrition plan, and all your problems are going to be solved, right? But we can think about things a little bit in the or through the lens of like exercise and nutrition, and go, are we at least ticking the boxes there so that we set ourselves up for better management of endometriosis? You know, like there's no real cure to endometriosis, at least as far as I'm aware of. So we're really just looking at management here. So on the training side of things, what are we thinking here, Nicola?
So yeah, so with training, I suppose it's getting, you know, any type of training in. You know, I know we're predominantly kind of go towards resistance training, but it depending on where someone's starting off, just even kind of low impact cardiovascular training, even starting off, you know, kind of 20 minutes a day, kind of 3 days a week. And again, that can help with you know, chronic pain and kind of just pain modulation as well. So starting off small and kind of, you know, building that up. Then you need to think about kind of modifications that need to be made for exercises as well. So particularly if you're a coach and, you know, your client has endometriosis, you know, do you have exercises that have them, you know, lying on their front? Do you have exercises where you might have a barbell across their hips that might be causing pain there? So it's just about kind of checking in and seeing what suits the person specifically. But yeah, definitely just getting some sort of exercise in is better than anything.
Yeah, the key here, in my mind at least, well, from my reading, it's like you basically just want to do some sort of exercise. It doesn't
Yeah.
actually matter too much. Like there's no like specific methods or protocols that seem to be better than others. We just want to get some sort of exercise in throughout the week. And again, depending on your starting point, that can look so different. That could literally, like you said, be like go for a walk for 20
Yeah.
minutes 3 times a week. Like that does help. And it helps in a number of ways. First of all, obviously, like exercise makes people feel better in general. Like they feel
Yeah.
like it's kind of like they used to have this like endorphin, whatever. That's not really true, but you kind of get this endorphin high. Like you feel good. You're like, oh yeah, like I enjoy that exercise. I feel good after it. Like you might not enjoy it while you're doing it. You might be like, oh, like I have to do the exercise, whatever. But generally, people feel good. So there is that mood elevation that you get from it, which that's obviously a symptom here. We've got mood disturbances potentially. So ideal. We've got something that can help with that. But also, like you noted, it does seem to help with the inflammatory condition here, right? Because exercise in general makes you better able to handle inflammation, which sounds like a bit of a misnomer, but you think about it here, you basically got this what's called a hormetic stressor. We've got a stress here in terms of the exercise we're doing. That's a stress on the body, right? Your body has to create a little bit of inflammation to deal with that stress, right? But in doing so, you actually get better at dealing with inflammation in general because you're like, oh, I know what to do with this inflammation. I know how to turn the dial of inflammation a lot better. I can turn it up and I can turn it down, right? So then when we deal with inflammation from other things, we're better able to turn the dial down. Now, it's not a cure-all. It's not like I'm going to say like you're crippled over in pain and I go, oh yeah, just do some exercise. Obviously, that's not helpful, right? But if we can build that baseline and build that kind of momentum behind you of doing some exercise a couple of times per week, you're going to be in a better position to deal with more information in future, right? And in general, like we just recommend that kind of 2 to 4 hours per week. Get that in. It could be resistance training, it could be cardio training, it could be just like light walking, whatever it is, whatever you can do, get in 2 to 4 hours per week. You're going to be in a much better position, right? Now, obviously, that's not to say that you have to start there. It's not to say that you have to start at that kind of like get in 4 hours per week. You could start at, again, whatever, 20 minutes per day, go for a little walk, whatever. All that stuff is going to help. But the one thing that I do want to say on this, especially for coaches that are listening to this, like you touched on the exercise variety, but also you should be thinking about program variety. And what I mean by that is like, how are you actually varying your training over a month, right? And we're going to use the archetypical like month here for, the female cycle. It's rarely that, but we'll just say the month, right? Like you should have within your plan, if you know you have a client that's coming in, they're like, right, every 4 weeks, I'm crippled over in pain. I'm in a lot of pain here. I can't be doing all these other exercises. Like, do we have variation built into the program, right? We can preempt that. We can do stuff like, okay, we're going to set the program up to your cycle. You seem to be quite regular, or maybe you're on the pill. So we have a little bit better control of this. We have a little bit more of like, we know what's happening when, and you're going to go, okay, we're going to have like, this is an easier week. You might change out the exercises. Again, some of the exercises you might be like, right, normally we do a hip thrust here because we want to build up the glutes or whatever. But, that's just when you're really feeling the pain, we have to swap that exercise out, and you have options. You have easier exercises, you have more moderate exercises, whatever, right? You can pre-organize that, right? What we generally recommend, especially for menstrual related pain, is having a more auto-regulatory approach to your training, right? And what I mean by that is you want to have an approach where some days, if you're feeling on fire, you're like, yes, I've got this. Like those days, you're going to push a little bit harder. On the days where you're a little bit more tired, you're going to take it a little bit easier. You can do this for, in general, like we generally recommend that. Just be like, right, look, life gets in the way. You're not going to always have this 10 out of 10 perfect training session. But especially with like endometriosis, like if you're in pain, and you want to get some exercise in, you might be able to do the same exercises you've been doing, but just use a lighter weight or don't go quite as close to failure. Like generally what we'll use is some sort of like RPE or reps in reserve, just as a kind of way to manage this. You might be going, okay, normally I do whatever, 100 kilos on my hip thrust, and I do it and I'm like very close to failure. I've got 2 reps in reserve. I'm very close to failure. We might go, okay, look, that exercise, we're not going to do that. It just seems to be causing pain for you right now, but we want to do some exercise for the glutes, but you're still in pain. We're going to do an exercise and we're going to keep you at, an RPE of like 5. It's just like going through the motions. Like it's still challenging, but it's not destroying you, you know? So we can modulate things both in terms of exercise selection and then also in terms of like rating of perceived exertion, or, you know, you could argue intensity, if you will, you know? But those kind of like auto-regulatory rails to the program seem to be quite beneficial so that you can continue exercising when you have endometriosis. You know, you can also build in things where it's like, okay, you know, during the time periods that you have a lot of pain, we're going to bring in really light exercise. You know, we're just going to get the body moving. If some of these things, you know, some people recommend like yoga and stuff, like sometimes that can be more painful because you have to engage your core a lot more. You know, you're in these random positions, like Pilates, for example. I saw a lot of people recommending Pilates, and 100% that can definitely help in general. But for some people, that's going to be more painful because you've got a lot of like core contraction there going on. And again, it's one of those things that you want to be aware of your own presentation, your own symptoms. You know, you might try it out one time and go, look, that's a no-go for me, you know? And so there are a few different things to be thinking about with training. I don't know if you have anything to add to that. And if not, what's the story with pelvic floor exercises? Because this is something that, again, you'll see people, you know, state in general for women, but is that related to endometriosis?
Yeah, so I think, you know, going back, definitely allowing yourself that flexibility to either, you know, change around the routine that you're doing or go easier is important. And just pushing through the pain isn't necessarily the best thing to do. And yeah, even for coaches, just knowing when to kind of pull back with the client as well. You might, if you're in this huge amount of pain, you know, not sleeping as well, you'll have a reduced ability to recover. So just kind of peeling back for a couple of days might lead to more progression kind of longer term. But definitely pelvic floor exercises can help for a lot of women, particularly with the dysmenorrhea. Again, I can't pronounce it myself. But working with pelvic health physio can be really beneficial for this as well. A lot of women with endometriosis might kind of have more tighter contracted pelvic floor. So definitely working with someone on that can improve symptoms.
Yeah, and that's also another one with the painful intercourse as well. Like a lot of women say that like those dilators and stuff, and doing pelvic floor exercises or working with a pelvic floor coach. I'm not going to say like doing pelvic floor exercises just like this is the be all and end all, but like there are options here. You know, there are things that you can do. This isn't just oh look, I have this issue, it's just completely write off. I'm just, you know, basically giving up on life, basically. You know, it's not the case. Like there are things that you can do. Yeah, we don't have a perfect, like here's our toolbox and here's the exact cure for this. You know, we don't have that, but we do have, you know, some solutions for different problems. And unfortunately, you just have to try a lot of different things out, talk to a lot of different people with regard to what has worked for them in similar situations. You might get a little bit of a clue. Like, again, I go on all those forums and stuff like Reddit or whatever, and like you see a lot of help in those places. You know, and some of it's misguided. Like we'll talk about supplements in a second, and some of it's just misguided. It's like this is probably not helpful, but it might give you ideas. It might give you something to talk about with your like primary care doctor or whatever, and go, can we try this? Have you seen success with this? Whatever, you know? But ultimately on the training front, look, basically you just need to do some sort of training. Find some training that you enjoy, find some training that you can continue doing, get it in throughout the week. Like it literally doesn't matter if it's just walking, jogging, you know, doing resistance training. You just want to do some sort of training. It seems to be beneficial for the vast majority of people. We have mechanistic reasons for why it would potentially be beneficial, and then also in the real world it seems to be beneficial, you know. Daily sporting exercise or daily activity seems to be the most protective, and in some cases it's, you know, better pain management than taking painkillers. That's in some studies that it's been shown to do that. But again, we have to look at this in terms of your actual experience. You know, we can't just go, yeah, if you start exercising every single day, that's going to be better than the painkillers you take. You know, that might not be the case, but we do have a lot of reason to believe that training in general, exercise in general is a good thing, right? Exactly. On the nutrition front now, Nicola, what's the story here? Because I think a lot of people think like, oh, there's going to be some sort of nutrition, like do this, and we've got this like perfect like plan of action for this. Because, you know, again, hormonally related stuff, or hormone related stuff, I should say, people tend to think like, oh, I can manipulate my nutrition here and I'm going to get this big effect. I'm going to get this, you know, 10,000% increase in testosterone, or, you know, I'm going to be able to modulate my cycle or whatever. And to an extent, We can, right? Because we talked about like amenorrhea, and that's obviously related to nutrition. But in general here, nutrition isn't that powerful a tool, right? It is quite a powerful tool, but in regard to endometriosis, I don't think it's that powerful. But what's the story?
So yeah, that's important to note. Like at the minute, there are no dietary recommendations for, prevention or treatment of endometriosis. And particularly in the kind of fitness world, you do see, kind of nutrition for endometriosis pop up. But right now we don't have any solid guidelines. But we do know that number of dietary changes, have been reported to reduce the severity of, menstrual pain and symptoms of endometriosis. So it is still important to, consider. And then just for general health, kind of having better nutrition is always going to be a net positive. But in general for endometriosis, so we know it's an inflammatory kind of driven state. So increasing anti-inflammatory foods, decreasing pro-inflammatory foods is going to be important here. So you're looking at kind of reducing your saturated fat intake, prioritizing unsaturated fats, kind of oily fish, your omegas, reducing like your kind of red meat intake as well has been shown to decrease the severity of symptoms. Now, knock-on effect, if you were to completely cut out your red meat and there's a lack of iron there, that's something that needs to be considered as well. So looking at kind of leaner cuts of red meat if you're going down that route. But yeah, reducing, your processed food intake. And then there's a lot of women that have kind of reported that actually going, even though they don't have they're not celiac, but actually having going gluten-free or having a reduced amount of gluten in the diet has shown a decrease in pain as well. And I know anecdotally from one of my clients as well finds the exact same thing. If they're kind of having a processed carb heavy day, they find that they have a lot more kind of cramping and pain. So that's one thing can help. And then you've a lot of other things that can help. So again, anecdotally, kind of high FODMAPs as well can kind of, irritate, kind of cause those IBS symptoms as well. So that's another thing. So diets high in fiber as well can be really helpful. So we know a lot of the estrogen kind of metabolites can kind of stick around. So fiber is going to be one of those things that kind of help kind of mop them up in the intestines and just kind of help excrete that estrogen. So kind of green cruciferous veg, they have a compound called DIM, and this is one of the big kind of supplements that you would see as well. But this is found in your green cruciferous veg like broccoli, kale, spinach. So what DIM does, it helps kind of break down the estrogen into kind of more favorable metabolites that can help it be excreted from the body. So prioritizing them in the diet can be helpful as well. And then as well, if you're having really painful, heavy periods, and there might be a lot of, menstrual bleeding, and that can lead to a loss of iron. So you're at higher risk of kind of iron deficiency anemia there as well. So prioritizing iron-rich foods, again, like your dark leafy green veg, fortified cereals, that sort of thing.
Yeah, 100%. And again, if you listen to any of our podcasts, it's basically the diet that we recommend for quite a lot of people. It's like, okay, let's get the baseline here. Let's go get a lot of fruit and veg in, right? That's start with that baseline. Get some lean proteins in. With regard to like endometriosis, there does seem to be this red meat link.
Yeah.
You're like, okay, look, you want to get some red meat in the diet. It is one of these ones where it's a bit of a balancing act, because we don't necessarily know if it was, say, the saturated fat from that red meat, because oftentimes that's a confounding factor. And we do know, or we seem to know at least, that saturated fat seems to be seems to be associated with endometriosis symptoms and, issues. So it could be the saturated fat, could be the red meat itself, but then we run into this issue of we need enough iron in the diet for everyone in general, but especially if you're having like heavy periods or whatever, you're going to need probably a little bit more iron, right? But then go for your red meat, and maybe you don't want to go for that because you're thinking that's associated with increased risk of symptoms related to endometriosis. But then maybe you also have a situation where certain veg doesn't sit right with you, like this kind of like higher FODMAP diet where you're eating a lot of different fruit and veg. That could actually be a negative for you, you know? And this is the thing about all of this stuff. It's not like we have the one key, we have the one perfect plan of action, you know? Like those high FODMAP foods could be associated with increases in, you know, endometriosis symptoms, that IBS. Like I did a podcast, you know, a couple of podcasts ago with Brian related to this. And it is one of those things where you almost get punished for doing the right thing. You know, you could start off and going, oh yeah, I'm going to eat a diet high in fruits and vegetables, right? That seems to be associated across the board with better health for a variety of people. You know, you get more fiber in, and like you said, that seems to help with, you know, the estrogen metabolism. You also seem to have these different like phytochemicals and bioactive compounds like this DIM, this DIM, which is diindolylmethane or whatever it is. You're like, oh, this has some benefit in terms of estrogen metabolism, puts them into a better position and they can be excreted. Cool. So we're getting all these different compounds, and we're getting in our anti-inflammatory, like antioxidants and all this stuff. You're going, yeah, this is great. And then all of a sudden you start noticing that your gut health deteriorates. You're getting way worse, like IBS. You're getting all this different stuff going on, and you're going, well, what the fuck, right? Now there might be a case of, you know, you kind of just need, you just change the diet. You know, you kind of need this, you know, week to 2 weeks to kind of let your body settle into it. But you could be doing everything right there and eating a lot of fruit and veg, and actually have some sort of like, you know, FODMAP sensitivity, you know, some issue with one of these foods or potentially a variety of these foods, you know. So you might have to do a little bit of an elimination style diet to kind of really pinpoint on those different issues, you know, what's going on there. And then it's the same with, you know, we generally recommend people eat like whole grains and, you know, good starchy carbohydrates that are, you know, unprocessed or whatever. And then you might have or be one of these people that seems to get some sort of like celiac-like symptoms, or, you know, non-celiac-like symptoms. Either way, you seem to react to something in the bread, some gluten, not in the bread, something in the grains. And you might be like, okay, so for me, I can't eat those things. And now maybe you also have this high FODMAP issue going on. So it can be very hard to really navigate all of this stuff. But having said that, once you get it right, like if you can really get the things dialed in, you potentially do have some sort of diet that is supportive of your endometriosis. You know, like we said at the start here in terms of this nutrition section, there's no general diet recommendations for prevention or treatment. We just don't have them, right? We do generally have some baseline diet recommendations for good general health, but we do also have now some information to potentially suggest, okay, these are some avenues that you can look at. You can, again, play with the dials here and go, okay, maybe I have a little bit less of that or a little bit more of that. And you can find a diet that is more supportive for you. Is it going to cure your endometriosis? Fuck no, you know, but is it going to support you? Potentially, right? And that's the thing with all this stuff. I can't give you a definitive, like, do this, it's going to help. If I could do that, or if I was, you know, a charlatan or whatever, and I was willing to do that, like, believe me, we can be making way more money. We could just write the endometriosis handbook. Here's the diet. Do this exact thing, you know? And we might produce more content in the future for endometriosis. You know, if people are like, oh, I really need help with this, we might do that. But we're always going to give you that caveat going like, look, we don't have the research to suggest that this is the be all and end all. For you, it might be, okay, I'm going to start off with this baseline diet. Then I'm going to test, like, am I actually feeling better with this? Oh no, okay, maybe I'm gonna have to switch out some of these fruits and vegetables based on this FODMAP approach. Didn't change anything. Okay, so that's not the issue, right? I've been having a lot of saturated fat. Okay, I'm gonna reduce that. Gonna change, get rid of any trans fats in the diet. Most trans fats are out of the diet these days, but, you know, maybe you do have some stuff in there, right? Like, okay, get rid of that. Nothing has changed. I'm eating red meat. Okay, maybe I'm gonna eat it only twice per week. So I'm still getting some iron in, but I'm not, you know, basing my diet on that. Nothing has changed. Okay, maybe you bring in some more like fatty fish. Okay, oh, now I'm starting to see some symptom relief here. Okay, there we go. We've got some little thread to pull on, right? So it is one of those things where you just have to keep tweaking. If you need help with this, like I know Brian does do a lot of stuff with, like, you know, menstrual related issues, PCOS and endometriosis. So he potentially can help. And I know, Nicola, I know you do obviously as well, help people with this stuff, you know. But I do want to say on the diet front, there's some weird ones that also seem to be like associated here, right? For example, like alcohol can negatively affect endometriosis, right? And we generally advocate, you know, lower alcohol diets. It seems to be better for health in general. I think most people are aware of that. But this is one of those things where it can actually be, hard to put in play, because you can imagine you've had a really rough day in work, you've been having these cramps all day, if your sleep has been a bit fucking off, and you're just a bit, you know, annoyed or whatever. You're gonna go home, crack open the red wine or whatever. You're like, okay, I just want to have like a relaxing evening. A lot of people do that in general, but that could actually be leading to worsening symptoms down the road. Like alcohol seems to negatively affect the symptomology of endometriosis. So it seems like it's a bit of a cure for the stress, the lifestyle related stuff, but it could actually be worsening symptoms down the road, which is, again, one of those shit things that you just have to fucking deal with. You have endometriosis, right? But then there's another one as well, which, again, like I actually have an anti-coffee bias, so this hit my bias perfectly. But coffee and caffeine are potentially bad for endometriosis risk and for symptoms, right? But the research on this is quite mixed. You know, my bias is to say, fuck it, like the caffeine, it's getting you, you know. But that's not 100% supported by the research, you know. But the reason I bring this up is because, again, we're not giving you the diet here. We're not giving you do this. I just want to make you aware that some of these things seem to be related, you know. Okay, you may have heard all of that and going, I'm doing all of that stuff, right? But I'm actually including alcohol in my diet. You pull that out and you go, okay, actually, I'm starting to get a little bit of symptom relief here. Or maybe you've been having 3, 4, 5, 6 cups of coffee per day, like a lot of people in the world, and you go, okay, I'm actually going to pull them out, or at least reduce them. Oh, now I'm actually seeing some sort of like symptom relief, you know. Like, I'm not telling you that you need to do this stuff, but I do want to make you aware of it so you can kind of go, okay, so there are a few different levers that we could potentially pull with this stuff, you know. So do you have anything else to say on the nutrition front, Nicola?
I think, like we were saying, you know, it is kind of just creating a baseline diet, and then you can play around with the things like you're saying, like red meat consumption, gluten. And one of the best things that you can do is keep a food and symptom diary, and just noticing trends. You know, if you were to have, you know, a lot of gluten, you know, 1 week, or kind of a lot of red meat 1 week, and just kind of noticing the trends. That's kind of one of the best things that you can do.
Yeah, and all of that stuff, it's actually very easy to do, but also very hard to do.
Yeah.
You know, like it's like, okay, all you have to do is keep track of the foods that you eat, right? And then also go, okay, what are my symptoms like this week or this month or whatever, right? But first of all, most people don't eat the same foods every single day, so you have to always be tracking. If you like, oh, what did I eat today or whatever, which, you know, that's fine. A lot of people track their food. Like, I personally like tracking my food, but a lot of people find that difficult just to stay on top of it. But then also the symptoms can be hard to correlate to what's going on in the diet, you know. Like, you can be like, okay, I've done all of this stuff, I've, you know, really dialed all this stuff in, but, you know, there could be a bit of a lag time. You know, it's 3 days later you feel the effects of that. It's a, you know, it's a couple of hours later you have your breakfast, and the breakfast was the issue, and then you have your lunch, and then all of a sudden you're starting to have like symptoms after lunch, and you're like, oh, it must have been the lunch, when in reality it was the breakfast because it's just been digesting or whatever. So it's very hard to really dial things in. And it's the same with an elimination style diet. Like, you can eliminate a load of different things, get symptom relief, but then you don't know which ones to introduce back in, because you're like, I seem to be having better like symptoms here. I seem to be having like better, you know, life going on here. I don't want to just play with it and go, oh yeah, I'll just bring this thing back in, and all of a sudden you've got more symptoms again. And, you know, you don't want that, right? So elimination style diets, or even like, you know, FODMAP reduction style diets, which is somewhat of an elimination style diet, it can be hard to do in practice. And that's generally, look, it's not, obviously it helps our business, but that's generally why we recommend like getting a nutritionist or someone to help you with this stuff, to navigate this stuff and go, okay, we're going to try this, see how it gets on. And you have that extra set of eyes looking at things, you know. But yeah, the next thing that we want to talk about is supplements, because this is the thing that most people turn to first of all, right? They're like, there must be a supplement, there must be some sort of like little magic pill that I can take. And look, I know it's so alluring. It's so alluring to be like, I can just take this supplement. I can go look on Amazon or iHerb or one of these sites and go, yeah, I'm going to buy this supplement. It says, you know, I was reading on Reddit or whatever, people said they have really good results with this. First of all, when you're reading something online, you don't know, that person could literally be a bot that's just designed to sell a certain product, you know. So you don't know that, first of all, right? And they could be paid to do these reviews or whatever. You just don't know, right? So it might not actually be associated with, you know, benefit. But also the research behind a lot of this stuff is just not like specific to endometriosis, and then it's just not well, some of it is specific to endometriosis, but a lot of it is just like mechanistic hypothesizing. You're like, okay, this seems to be a mechanism in endometriosis. This supplement seems to be, able to help with that mechanism in this like cell culture. Cool, let's pair them together. It's good to go. But we don't have that kind of robust in-person data, right? But having said that, there are some supplements that we could be like, okay, maybe there's a little bit more support for this. Other ones, maybe we can get them from the diet. If we just eat a good diet, we don't need to be focusing on this, right? But we'll go through them. So the first one here is just like omega-3s, right? A lot of people, they just don't consume enough omega-3s. If you're not eating any fatty fish throughout the week, like chances are you're not consuming enough omega-3s, right? Yes, for sure, you can get them in, certain other foods, like, there is some omega-3s in vegetables and stuff like that. But for the vast majority of people, the easiest way to get this in is to consume some sort of fatty fish, right? So if you're unable or unwilling to eat some fatty fish, you're just going to have to supplement, and we've talked about this before, especially related to like, vegetarian style dieting. There are vegetarian and plant-based options for this stuff. It doesn't mean that you have to consume like fish products, but for most people, supplementing with some sort of omega-3 is going to be beneficial, right? Is it going to be a cure-all? No, but it does seem to be associated with reductions in inflammation and pain severity, right? So we have at least something, right? It's not going to be a cure-all. I'm not going to say it's going to go 50% reduction in your pain or whatever, but it's going to help. It's going to contribute to pain reduction, reducing inflammation, right? It might not for you if you're eating a lot of fatty fish already. Supplementing on top of that, it's not like more is better. There's just you need to be getting a certain amount, right? Do you have anything to say on the omega-3 front?
No, that definitely not. But yeah, if you're not getting it in, if you're not going to have, oily kind of fatty fish, definitely supplementing is something to consider.
Then the next one here, I'm basically going to go through a few of these that I just saw online that I was like, look, there's, and looked up the research on it, and there's some of them that are like, yeah, okay, we just really don't need to do this. But some of them actually kind of surprised me when I was like, oh, actually, yeah, mechanistically, this makes sense, but there's actually some other stuff going on, right? Like curcumin, right? Which is in turmeric. I always get confused. It's in turmeric or turmeric is in curcumin, whichever way it is. I think curcumin is in.
It's in turmeric, yeah.
In turmeric, right? So I don't know if you eat maybe a lot of like curries or something, potentially you're getting some curcumin in your diet, but the vast majority of people are just not consuming a huge amount of curcumin. So potentially supplementing with it is going to be beneficial. And the reason it's potentially beneficial in the cases of endometriosis is it does seem to reduce inflammation. That's just in general, it does seem to have anti-inflammatory properties. That's not that magical. A lot of plant-based products seem to have anti-inflammatory properties, but curcumin does potentially suppress the growth of endometriosis cells, right? So that was one that surprised me. And it's one of those ones that's like, okay, look, the research on this is not like robust. It's not like they have like thousands upon thousands of women. They're like, right, here you go. Here's a curcumin supplement and take this and let's assess the like endometriosis, that you have, right? It's not like we have that data. We do have some data like that. But we do also have some data like in cells or in animal models that seems to support this, right? So, curcumin is fairly innocuous in terms of it's not going to cause a huge amount of harm. In my mind, I'm like, look, try it, see if it helps, right? Generally, I'm not an advocate of just try it and see. But with curcumin, there doesn't seem to be any huge risk of taking it, right? At least from my understanding. Obviously, always do your own due diligence and look into this stuff yourself. Examine.com is always a great website to go on when you're looking at supplements. So look into that, see if it is potentially something that you want to investigate. But again, this is not going to be a game changer, at least from my understanding. It's not going to be something that's like, oh yeah, like this is going to really help. It's going to cure everything. Not really, right? Do you have anything to say on curcumin?
No, it's just one of those ones that kind of claims to cure everything, I think, curcumin. So I think it's something maybe to add into already, like we were talking about, that kind of base diet. It's not something I'd be looking at improving the diet before kind of adding something like that in. And then looking at the different supplements, some of them are terrible. So looking at one kind of a good bioavailability with it as well.
Yeah, like a lot of them have biopiperine.
Yeah.
As well, which does seem to help with that, uptake of it, we'll say. There are other ones like liposomal curcumin and all this different stuff. Like, yeah, we can get down the rabbit hole of that stuff. Again, go to examine.com. That's the best way to look at this stuff. Like, we don't get any benefit from telling you to go to examine.com. We just, we use it ourselves, right? And then there are some other supplements that people often recommend with this stuff, and some of them are potentially, we could argue potentially helpful, but again, it's this kind of mechanistic hypothesizing. It's not something that I'd be like, this is our front line, this is what we do, this is the first, you come to me, you have endometriosis, and I give you this laundry list of supplements. That's not what's happening. We're going diet first, right? But we can supplement with that diindolylmethane, right? That DIM that you get from cruciferous vegetables, right? And that could potentially help with estrogen metabolism. There's other supplements, and nutrients as well, that can be found in the diet or in supplement form that can potentially also help with estrogen metabolism. One of those is calcium D-glucarate, right? So a lot of people you'll find online, they do recommend this kind of diindolylmethane, this DIM, and calcium D-glucarate, right? And some people find some symptom relief from that, right? Is it something that I'd be like, yeah, look, this is 100% really well supported? No. But is it potentially something that could, maybe add a little bit to it? Maybe. I don't know. Like, I'm not convinced by the research. I'm not 100%, like, oh, this is going to be the game changer. Like, I've taken diindolylmethane myself, and it just made my pee smell a bit weird. But it didn't really do anything in terms of changing my blood lipids or not my blood lipids, my blood work in terms of my estrogen. So for me, I'm not convinced about its efficacy. Now, you can always argue, oh, like, maybe you should take some more or whatever, but like, I'm not convinced, right? And also with any of this hormonal stuff, like, oftentimes people think like, oh, I'll just, lash a few different products in and it'll change the hormonal environment. And okay, that might work. It might actually do stuff, right? But that doesn't mean that it's beneficial. You might be thinking like, oh, this is an estrogen mediated, issue, but that doesn't mean that just lowering your estrogen to fucking hypogonadal levels is beneficial, right? So we do want to be aware of that. Not that I'm saying that these supplements could do that, but it is something to be aware of, right? There are other ones that are also recommended in regard to hormonal related things. And one of them is Vitex, right? It has some big long name that I always forget, but Vitex is often recommended. And look, I really don't see the benefit of this. It does seem to increase estrogen in a lot of people. It's one of those ones that seems to be like this cure-all, again in air quotes, for any female health related issue. Everyone's like, oh, take some Vitex, it seems to help with hormonal regulation. And yeah, in some cases it does help, right? It can definitely be supportive in certain cases, right? But if this is an estrogen mediated issue and Vitex potentially increases your estrogen, right, it wouldn't be one that I'd be like, this is the one that we go for. Some people might find relief from it, or relief with it, I should say. But it's just not, I wouldn't be supportive of it. I wouldn't be like, this is something that we should try. I just bring it to your awareness though, because again, I know people search these message boards or whatever, and they're like, oh, this is the supplement. They have this shopping cart of like 200 pounds worth of fucking stuff in there, thinking, like, I'll take all of these every single day, do you have anything to say on any of those like estrogen related or hormone related supplements?
Yeah, like, I think the thing is that our endocrine system is such a complex system, and it's likely that, some people that are reporting benefits, it is likely that some people will benefit from some of these things. But like I said, the whole system is so complex, and we don't know how we as individuals are going to react to say each of these supplements or a dietary intervention or anything at all.
100%. And again, look, we think that we are gods in this world. We think we're like, oh yeah, like I can just, do whatever I want. I'm master of the universe here. But like, we're really not. Like, we have a basic grasp of this stuff. We're basically just hairless monkeys here. So like, you can mess with this stuff, but it doesn't mean that you're going to mess with it in the right way, There are some other supplements that seem to be, somewhat supported. N-acetylcysteine. I've said it before, I take N-acetylcysteine. It's great for liver health, great for a few different things. Isn't something that I'd be like, oh, everyone needs to be taking this. However, for endometriosis, it does seem to be associated with reduced cyst size and growth, So again, that's one that I'm like, look, very little harm in taking this, like, potentially, it's but what I always recommend is, again, examine.com, see if it's right for you. You also get like the different recommendations in terms of how much you should be taking and all that kind of stuff. Do you have anything to say on that NAC, or NAC as people sometimes call it? Cool. Magnesium, magnesium is one of those ones that you can get enough from your diet, especially if you're eating a lot of green leafy vegetables. But it is also one of those ones that seems to be associated with, first of all, reductions in period related pains in general, right? A lot of women will say that if they're like, oh, I just take some magnesium when I'm having like period cramps or when I'm on my period or in the lead up to my period. And they're like, I seem to get symptom relief from that. Oftentimes it's this, again, my monkey brain, the way I think of it is, I'm like, look, calcium is associated with muscle contraction, like you need calcium to contract your muscles. And then magnesium is associated with muscle relaxation. That's not really true, but that's kind of the way my monkey brain thinks about it. Like magnesium is actually really important in the body overall. They always quote that figure of it's always associated with like over 300 enzymatic reactions in the body. And that is because, well, it's for a variety of reasons, but magnesium is actually bound to ATP. So if you have any like energy related things going on, anything that requires energy, like it's ATP mg, it has that magnesium associated with it, right? But in regard to endometriosis, it does seem to be associated with reduced pain experience due to dysmenorrhea by lowering inflammatory stuff going on. And it also has anti-spasmodic and muscle relaxing properties, right? Now, most people can get enough magnesium from their diet, but also it's kind of easy to just add a little bit more magnesium to the diet in supplement form. There are better and worse magnesium supplements. And it's one of those ones where I'm like, yeah, look, try it out. Like, and I have some magnesium in the press there. It's like, it's not a huge issue to take some magnesium, at least in my experience. Like, I'm not a doctor. I'm not telling people what to take, but magnesium is fairly harmless as long as you're not just megadosing it. And I don't think most people would want to megadose it, because if you just haven't used a powder or whatever, like it's not great. And if you do megadose it, you're probably just going to shit it out, because it has, like, again, similar properties in the intestines and stuff, but magnesium, you going to say on that, Nicola?
No, it's one that's commonly recommended for a lot of kind of menstrual cycle kind of dysfunction or irregularities. So it can, improve cramps, and as well as another benefit of improving sleep as well, which it's a commonly recommended sleep supplement. So that can be very beneficial before bed, especially if someone's experiencing pain or disrupted sleep from having endometriosis.
Exactly. Then the next few are really just vitamins. One is a sleep related one, which I'll talk about in a second. But B vitamins, right? If you're just not getting enough B vitamins, obviously you're not going to be able to process things effectively, right? B vitamins are just like, they're basically the foundational vitamin in the diet, right? Because they do everything. They're basically a class of vitamins, and they seem to be involved in pretty much every reaction in the body in some way, shape, or form, right? Now, in relation to endometriosis, we could argue that they're involved in the inflammatory cascades and estrogen metabolism. So if you don't have enough B vitamins, that inflammation cycle and your estrogen metabolism is not going to be where we want it. However, it's also very easy to get enough B vitamins from the diet. Like, if you eat some fruit and vegetables, like, you're kind of good to go, right? Some of them you do need to get in meat, but like, you're kind of good to go in regards to your B vitamins, as long as you're consuming a well-balanced diet, right? However, if you are a person that maybe you're dealing with some sort of IBS, or maybe you have like a FODMAP sensitivity and you have to eat a little bit lower vegetables than you would potentially like, maybe in that case, taking some B vitamins can be helpful. Maybe just take a multivitamin. So you're like, right, I'm just going to cover my bases. They generally include enough of those B vitamins as well. But it isn't one that I would be like, you need to consume this. You absolutely need to consume this. If you over consume those B vitamins, you're just going to piss them out anyway, So you basically just get expensive piss if you're eating enough. So save yourself the money and just eat a well-balanced diet, You don't have anything else to say on the B vitamins?
Yeah, food first approach, like you were saying.
Yeah. Next one then is vitamin D. This is often recommended in, regardless of the hormonal situation. People are like, oh yeah, you need to get some vitamin D. If you have low testosterone, vitamin D. If you have high testosterone, vitamin D. If you have low estrogen, vitamin D. If you have high estrogen, vitamin D. It just seems to be recommended across the board, right? It does also seem to be associated with reductions in inflammation. And in general, we do seem to see that kind of better hormonal balance from taking vitamin D. A lot of people in the northern and maybe southern latitudes as well, I haven't looked into that as much, but in like Europe and stuff, we do seem to be, and North America do seem to be a little bit deficient in vitamin D. Now, that's not to say that you just go out and take 10,000 IU every single day. Like, most people don't need that much. But if you are someone that sits indoors all day and maybe you're not out in the sun at all, you're going to need to take some sort of vitamin D, right? Vitamin D, potentially beneficial here. I generally recommend most people. I'm a bit of a vitamin D advocate. I'm like, look, take 1,000 to 2,000 IUs per day, maybe less during the summer, or maybe just don't take it during the summer. Like, this stuff it is fat soluble, so you can store it. So, just get outside into the sun if you can. Like yesterday in London, it was a scorcher, so I got a lot of sun. Didn't take my vitamin D yesterday as a result of that. And today it's very overcast, very cloudy. I'll probably take some vitamin D, So this is one of those ones where I'm like, look, you don't necessarily need to take this every single day. You don't need to take it year round, but it is potentially beneficial for endometriosis, as well as a whole host of other issues and whatever, you don't have anything else to say on vitamin D?
No, it says it's yourself, it's associated with like a whole host of chronic diseases, and particularly with endometriosis, supplementation kind of before menstruation has been associated with kind of reduction in pain and reduction in the use of painkillers as well, which is interesting.
So get that D in. Next one is, well, I'll add these two together: vitamin C and vitamin E, right? They're antioxidants. They do a lot of other things in the body, but they are antioxidants. Vitamin C is often associated with like immune boosting, and it is technically your immune system that is clearing the endometrial cells that get to other places. Like, it's your immune system that's recognizing, oh, this shouldn't be here, right? So we do want to have that good immune system, right? So vitamin C potentially having a benefit here with regard to endometriosis, but I would probably lay my hat more on the antioxidant, that kind of anti-inflammatory benefit from vitamin C, right? Same with vitamin E, has that antioxidant benefit. I don't think you need to supplement with either of these. If you are just eating a lot of fruit and veg, like, you're kind of good to go. If you're eating some sort of like vegetable oil, like olive oil, for example, which we often recommend, get some like extra virgin olive oil, does have, generally speaking, a lot of vitamin E in it as well. So you don't necessarily need to supplement with either of those. I don't need to say anything more on that, really. It's an antioxidant, right? Melatonin, right? This is one that technically it's a supplement. Technically it's like a hormone in the body, or at least a signaling messenger in the body. It is also illegal in Ireland, as far as I'm aware. It's not illegal in England, as far as I'm aware as well. I know it's not illegal in a lot of the countries in like continental Europe, France, whatever. Like, you can get, I was in Paris, like whatever, in December it was, January, whenever it was, and like they literally just sold melatonin over the counter. And being from Ireland, I'm like, you can't get melatonin in Ireland, right? But melatonin is that kind of, whatever you want to call it, that sleep hormone, if you will, right? It is that hormone that, initiates the sleepiness, I suppose. So it is also an antioxidant, right? So it does have antioxidant properties in the body, which is beneficial here. Melatonin is also associated with, hormones in a few different ways. Some people say it's a negative, like people with women who have higher levels of melatonin in like their teens seem to have a delayed menarche, right? They seem to get their periods later, right? That's not necessarily a bad thing, that's not necessarily an issue, but because of that, some people go, oh, like it delays puberty. No bueno, and you can induce this in rats and stuff, and lab, mice or whatever. It's like, okay, give them melatonin and they have delayed menarche, right? So that is one of those things where it's like people have this little bit of a negative connotation with it, but also some people have a positive connotation with it, because it does also seem to benefit hormonal health in general, right? Just like we have a general, like a food first approach with this stuff, we have a sleep first approach. So like you can supplement with melatonin. Well, in Ireland, you can't supplement with it unless you're on the black market, right? But in general, like, I know a lot of people from across the world listen to this, like, you can get melatonin, right? You can supplement with it. A lot of people think, oh, more is better, and they're in these like 3, 5, 10 milligram doses. You really don't need that much. You really need a very, very small amount, right? Like, I'm talking like less than a gram, right? Is it in grams or milligrams? Either way, right? You need very, very little. Go to examine.com. They'll tell you the actual numbers, so I'm not just remembering them off the top of my head, right? But you need very, very little to actually get the effects, right? A lot of people will take more because more does work more effectively in the short term, but we don't want to be chronically supplementing with that, right? And it can be beneficial for like stuff like jet lag. If you're like traveling all over the place and you're like, I need to be able to get to sleep at certain times or whatever, it can be beneficial for that. But when we're talking about something that you're going to have to potentially benefit or to supplement with chronically, I would rather just see you get to sleep earlier. I'd rather just see you get your sleep sorted. Now, this is a particular issue for people with endometriosis because you potentially are in pain. The sleeping can be potentially harder to get because you're in pain, right? So it is a little bit of a chicken or egg situation where you're like, yeah, getting better sleep would benefit you, but it's hard to get better sleep, but you can still do things, really encourage like better sleep hygiene practices, like, the last hour, 2 hours before bed, like you're really trying to initiate that kind of sleepy drive. And you're trying to do stuff like minimize your blue light exposure. You're not getting like really hyped up. You're not taking like caffeine throughout the day, like later in the day, like stuff like that, For me, I'm like, you don't need to supplement with melatonin if you're doing everything right sleep wise, but do you have any other, either supplements that you've heard of, people recommended, or do you have anything on any of those supplements that you're like, oh, we should have mentioned that?
No, I think that was pretty comprehensive. Yeah.
Fantastic. So the final few little things is just the lifestyle related stuff, right? And I'm not going to, belabor the point here because we talk about it all the time. We want to have good stress management practices and we want to have good sleep practices. I'm not going to go into them too in depth here because we've talked about them a million times. So go back and listen to all of our podcasts and you'll hear 1,000,001 different tips for all of that stuff. But do you have anything else to note on the lifestyle related stuff? Anything else?
No, not really. Just, like managing your stress, managing your sleep, again, just can, help with reductions in pain as well.
Fantastic. And then the final thing I wanted to touch on, well, I don't want to touch on it, I want you to touch on it, is like medical interventions, right? Because there are a few questions related to this stuff and I'm not in a position to answer these, but in relation to like drugs, right, is the use of painkillers okay? Because that's something that people really worry about. They're like, oh, like, is there long-term side effects to this? Is it okay to be using this? Should I avoid it? Should I just like, grin and bear it? What's the story there with painkillers?
So the thing is with painkillers or any of the medication, they're really not going to, kind of treat the endometriosis. It's not going to cure it. It's really kind of like a surgical disease that if you want to kind of really kind of treat this, you want to be taking out that tissue. So in terms of people, it depends, again, you'd be working with your GP on this, on the severity of symptoms. So if someone that has kind of a mild, moderate endometriosis, kind of a mixture of non-steroidal anti-inflammatories like your ibuprofen, mixture of that and the pill, can help with symptoms. Again, you're not getting to the root cause. But yeah, kind of the use of painkillers, particularly around whether you get the mid-cycle pain, or whether it's around your period that you get the worst pain. So a mixture of those two is generally what's used. There are other kind of hormonal treatments, like gonadotropin releasing hormone is also used. We're not really sure kind of which has a better kind of efficacy for treating, for managing symptoms. And again, that will just come down to, the person, their GP, and what might suit them best. But yeah, it's fine to use painkillers, again, in short term, if you've no other kind of, comorbidities or kidney issues. You might, if you're on them long term, you might be looking at something that you might kind of need, like a stomach protectant tablet, like a PPI, that sort of thing. Again, it's not something that I would take upon myself to decide to be on painkillers long term.
Because I know that is something that people really do kind of worry about, because some people just like pop them like they're or whatever, and I don't think that's necessarily beneficial, but also I'm not the one that's dealing with the pain, so that's the thing. But then you also mentioned it there, the pill, right? This is another one that people kind of go like, should I be taking it? Like, is it just masking the symptoms and I'm just going to get them back? Like we talked about earlier on, like you could be this 32-year-old woman or whatever and go, yeah, I've been on the pill for the last 20 years odd, and now I want to get pregnant and I come off the pill and now I have all these issues, but the pill, is it something that we should be thinking about, oh, this is something that could potentially help here, or is it something that we should maybe be avoiding?
Yeah, well, it's definitely something that can help with symptom management. And again, it is more so just, it is primarily going to be for symptom management. And there are, some cases that it can kind of, reduce the size of the endometrial-like tissue that's scattered around the place, but not for the endometrioma. So that's kind of the cysts that are kind of within the ovaries. So it is important, I suppose, to know whether you have one of those endometriomas, like we said, that they can, cause almost like erosion into the ovaries. So in that kind of sense, maybe the pill would be masking something like that. But again, it's really something that, kind of you and your GP will be deciding what the best option is. It depends what you're looking for. Are you looking for, are you looking to have a baby? Are you looking to just manage the symptoms? So it depends what's appropriate for the person.
Yeah, like it sounds to me like it's definitely something that's beneficial for symptom relief, you know? So if
Yeah.
that you're like, look, I just really need to get a handle on these symptoms. I'm really in pain. It's debilitating. It's interfering with my work or whatever it is, right? Yeah, it seems to be all systems go. Obviously, talk to your doctor, etc. Right? But it also seems to be one of those things where you have to be a little bit more cautious in terms of thinking like, right, this could potentially cause issues down the line, not the actual pill itself, but more so the fact that it could be masking the fact that you have like a cyst on one of your ovaries or both of your ovaries, and that could potentially lead to infertility down the road. You know, you could be coming off the pill again in your 30s and going, now it's ready to have a child. I'm willing to deal with the symptoms or whatever, but you've actually you've masked the fact that you've had like cysts on your ovaries for the last 5 years, so it is one of those things. At least for me, I would be looking at that going, yeah, definite symptom relief here, definite benefit in that regard, but I just want to make sure that I'm looking after the ovaries. And how would you do that? Would you get like an ultrasound on the ovaries? Like how would it be diagnosed that there is like something going on the ovaries? Is that something that we could actually be aware of ahead of time, or is it, and this kind of goes into the next thing, is it something that like it's a surgery that you have to do, we have to see it?
Yeah, so the gold standard is surgical intervention. Like there are other things you can do, like a transvaginal ultrasound, it may or may not necessarily like pick it up. But surgical intervention, like a kind of like your keyhole surgery, is kind of the gold standard for diagnosis of endometriosis.
Cool. And then on the surgery side of things, because this is obviously something that scares a lot of people, right? I've never had a surgery, so I don't know. I've never had to deal with those thoughts. But if someone came to me and said like, okay, we're going to have to do a surgery to just investigate, I would be like, okay, that seems a bit like invasive, because it is, right? But then if they also said like, oh, we have to do a surgery to like remove some of this tissue, right? Seems a bit, intensive as well. But then also, if you said we have to do a surgery to like remove like part of your ovaries or part of your womb or whatever, or your whole womb, you get a hysterectomy or whatever it is, like that also seems incredibly invasive. So how do we think about this whole like surgical environment, both in terms of like the actual like practical, like, okay, this is a surgery that I have to do, but then also potentially like you're getting a diagnosis of endometriosis and they're telling you that, you're infertile and you're maybe a 28-year-old woman here going,
Yeah.
oh, I wanted to have kids, like how do we think about that whole spectrum?
Yeah, so like making the surgical decision, it's a big decision to make. So it is something that people will try to avoid, and surgeons will try to avoid unless symptoms are really severe. Even with the laparoscopic, intervention, it still is like you're saying, a big deal. Like a hysterectomy in itself, again, it's an even bigger deal. You're essentially putting someone into an early menopause. Which we've spoken previous podcasts have, impacts on your bone health, cardiovascular health, etc. So it's not something that can be taken lightly. And as well, even having a hysterectomy doesn't mean that that's not the cure for endometriosis either. Like we said, they can still pop up in, the bowel, rarely like the lung or, any tissue really in the body. So it's not exactly, having a hysterectomy can improve symptoms, but it's not exactly curative either.
Mm. And again, it is one of those things, because again, I was reading on all those different forums and stuff, going like, okay, well, what are people saying? And people will say stuff like, oh, I got surgery and I'm still in pain. It's not one of those things where this is a cure-all. So like I don't like giving people false hope. I don't be like, oh, this is the key, because it kind of like when you find something, you're like, oh, we seem to have the answer to this. You kind of want to give people hope. You want to be able to go, oh, like we have the answer to this. But with endometriosis, it seems like one of those things where it's just so complex. It's so like multivariant that you're kind of like, we have to trial a few different things and they're not all going to work, you know? But yeah, look, I don't really have anything else to say on endometriosis in general. Is there anything that you think we should have covered or that we forgot to cover that you want to mention now?
No, I think we got through most things. Like I said, just if you're someone with quite significant, period pain, heavy periods, a lot of pelvic pain, it is something that, you shouldn't have to put up with. So it is worth going and speaking to your GP if you're worried about it.
100%. And again, especially because this is like a silent one potentially, you could just be like, oh, that's normal, that's my normal cycle. I've always had a cycle like that, it can be, again, the average time is 8 years, as you said, 8 years of diagnosis. And that can obviously be made, longer if you're not willing to go in and actually talk to the doctor and, discuss the pain that you're in, but anyway, look, that's endometriosis. I'm sure there's other things that could potentially be doing. Like, this is just our understanding at the moment. This is just our understanding in terms of the research that we've read, the experience that we've had, etc. Nicola is a doctor as well, obviously, so she has doctor training, but we do plan on putting more information out in terms of female health in general. Obviously, this podcast series is one way we're doing it. So if you're not subscribed, please subscribe to the podcast. If you find a benefit from this, share it on your Instagram, etc. I know a lot of people have been sharing it on Instagram, saying that they're really enjoying the podcast series. Just make sure you tag us, otherwise I won't see it. But yeah, so other than that, don't have much else to say. You can find us in all the usual places in terms of social media. They're all linked below. Instagram is our main hub. You can go find us on our website as well. We do have coaching spaces available, both for like just full coaching package, training and nutrition, and then nutrition only. And if you're looking for female related help, look, Dr. Nicola here, she does still have spaces available. So if you're interested in that, look, just get in touch. We'll talk you through the process and we'll see if it's a good fit, if we can actually help you, right? Other than that, I don't have much else to say. So yeah, we'll see you all in the next episode.